Thank you so much for joining us. I'm Judy Krasna, the Executive Director of F.E.A.S.T, and we're thrilled to have you here with us today. I just want to start with a few brief announcements. First of all, please make sure that your camera and microphone are off now and stay off throughout the duration of the webinar. And if you have questions during the webinar, you can just drop them in the chat box, and Professor Waller will get to them at the end of the webinar, as many as we have time for. And I think that's all for the announcements. Oh, one more is Professor Waller graciously shared his slides with us already, because that's usually the first question that shows up in the chat box is, can we get the slides? So we will be popping that into the chat feature. So you can all benefit from those slides. You know, you can look at them throughout the webinar and you can look at them when the webinar is over. So now it is my pleasure to introduce today's presenter. Glenn Waller is a professor of clinical psychology. His clinical and academic specialisms are evidence-based CBT for eating disorders and why clinicians drift from effective treatment. He has published over 325 peer-reviewed papers, 20 book chapters, and 4 books in the field, and regularly presents workshops at national and international meetings. Professor Waller is the past president of the International Academy for Eating Disorders and is on the editorial board of Behavior Research and Therapy. He was a member of the NICE Eating Disorders Guideline Development Group, responsible for the 2017 update to the Eating Disorders Guideline. Thank you very much, Professor Waller, for being here with us today.
Okay. Whoa, I seem to have completely mislaid myself. Excuse me while I put my slides up. And boom. Just making sure I have the right ones. Okay, I'm hoping you can see those okay. Yeah, Judy, is that okay? Great. First thing you all notice about me is technological incompetence, so please bear with me here. The other thing is you might occasionally hear the sound of a dog snuffling around hoping to get a biscuit. If you can bear with that, we can get along. Right, well, thank you, everybody. I have to admit, when I first agreed to this, I thought, well, there might be 5 or 6 people, but hell, you've surprised me. I'll cope with that somehow. What I'd like to do is really just give you a really simple guide for beginners about a topic that for a lot of people is seen as being very complex, but actually I think shouldn't be seen as complex. It's just about helping people get as well as we can. So I'm going to talk about this therapy. I'm going to talk about where it sits in the broader field. I'm going to talk about the ways in which it can be effective. And hopefully that will give you that introduction you need to understand what we're talking about. So if you'll bear with me, I'm going to first of all say to you, well, why should you consider CBT for eating disorders? I think it was calculation that was done by one of my colleagues that he managed to find over 600 therapies labeled as being for eating disorders. This is just one. Why should you bother with this one? Secondly, what it involves at the CBT level, because we need to understand it comes from a much broader therapy area. And then what does CBT for eating disorders itself involve? Then I want to take you through some of the key therapy skills so that if you're doing it or if a relative is doing CBT for eating disorders, it shouldn't come as a surprise. And then I want to talk about that nagging little doubt in the back of my head about how none of our therapies are perfect and it would be really nice to improve on them and what kind of directions we might be going in, given the early evidence that we've got going on at the moment. So I'm going to kick off with why consider CBT for eating disorders. And this, as I say, should be a very real question. It shouldn't be automatic that we do. So I'm going to start out with the kind of very key thing about evidence-based therapies. We are here to, as therapists, to get as many people as well as possible. I'm hoping that's not a point of contention. We run various training courses, and that's our first line of almost anything. We are not going to get everybody well. No therapy works for everybody, but some work better than other people or than other therapies. Unfortunately, we have very little evidence that one treatment works better than another for specific individuals, apart from FBT for younger cases. So it's not possible to say we have really good matching criteria for treatment. So general rule of thumb, when you don't know which is going to work best, start with the one that works better than the others. And then if that doesn't work, think about what to use afterwards. Now, evidence-based therapies are for nerds, and I'm a nerd. You might call it a geek. I'm not entirely sure. It's a translational issue. But for people like me, that issue of how many people get well is real important. I'm a clinician, I'm a researcher, I'm a bit of everything. And the critical thing for me is, what can we do better than we did yesterday? The problem that we hit in this field, and this applies across psychological therapies, across disorders, is clinicians rather like judging what would be best for the patient rather than using the evidence. Sometimes they do this by saying, well, I'm offering therapies that are informed by the best therapy rather than are the best therapy. The difficulty with that, the reason I want to keep bringing us back to evidence-based therapies is that when you look at the effectiveness of judgment-based therapies, I'm not going to pay attention to the evidence-based, I'm going to go off my clinical nous. They're far less effective than the manualized approaches that I'm going to be talking about, such as CBT, such as FBT. And it's about a third of the impact. That's a huge difference. It's the difference between getting maybe half of your patients well and maybe 15% of your patients well. And I think we owe it to people to give them the best that's available. The problem with those therapies informed by various models is that they're usually quite bitty. They've usually got problems like they lack coherence, their favorite bit here, favorite bit there, or they miss key elements. One of my favorite terms is when you're thinking about CBT, what you don't want to do is take away all the effective ingredients and end up with what we call CBTH or CBT at a homeopathic dose. There's nothing special about the word CBT. So let's assume we actually need to do the stuff. The biggest problem with these informed by models is they just plain lack evidence. And while I would not for 1 minute say we can only ever do the therapies that we know work now, I think we should, by all that's right, we should owe it to our patients to make sure that we help people improve as much as we can. And that involves getting better at doing good therapies rather than just accepting weaker therapies. So that's my nerd position. In fact, when we put together a self-help book, which you can see just illustrated down there, we gave some points for carers and for sufferers. And one of the points we made in our points to raise was if you go to a clinician and say, I'd like to get help, you should also say, can you show me how effective this treatment is? And if the clinician can't tell you because they don't pay attention to whether it works, walk out the door backwards very quietly, but don't engage with something that's got a very good chance of being a waste of money. Now, I'm aware that's an extreme position, but I'm extreme enough to like seeing people get well, so I'll stick with that one for now. Fortunately, we do have evidence that we have therapies that work. This is not me, this is not me disrespecting things like mantra or SSCM or FBT. I have great respect for all of those for the right groups. However, CBT for eating disorders, CBT-ED, has got good evidence. If you look down on the left there, you'll see the NICE guidance on working with eating disorders, and you'll see the APA guideline, which is a collection of national guidelines. And they both come through very strongly. For most people with an eating disorder, start with CBT. Now, if you're underweight, you want to be thinking about a range of different possibilities. If you're adolescent, you'll want to be thinking about FBT as a beginning point. If you've got ARFID, there is some really new, great evidence from Jenny Thomas and Cameron Eddy and their team about the impact of CBT for ARFID as well. So we've got several evidence-based versions of CBT. The books on the right are the ones that largely say they've got the best evidence behind them. Now, I've mentioned FBT. We know FBT is a great first line for people who are younger. However, there comes a point where it's less effective. As you get towards about 16, 17, you start seeing that differential effect drop off. And this is where CBT can be helpful as well. You also, and this is a point Miriam Craig made in her rather wonderful paper a couple of years ago, there comes a point where you have to acknowledge not every person with an eating disorder wants their family involved. Not every family wants to be involved. And sometimes FBT doesn't work. So CBT as a good backup for those cases, it's actually proves to be really effective in those cases, as effective as if the person were an adult going into treatment for the first time. So I would say think about CBT as your backup if you're younger, but a good option if FBT isn't working or isn't viable. The nice bit about this evidence is it goes wide. It's not just this will work in a research setting. It's been tested out in many, many places for real life effectiveness, and the outcomes of CBT in the clinic down the road from you can be just as effective as it is in the big research trials if it is done appropriately. That's a critical point. I'll be coming back to that. If you look at that diagram on the top right, you'll see the kind of proportion drop that you see. People start out in that blue line with a pathological level of eating attitudes. In this case, the same applies to the whole range of symptoms. It gets lower by halfway through, and it's below the clinical cutoff by the end. That's what you want to see. The nice bit about that is the diagram on the right shows exactly the same pattern, but you can do that in 10 sessions. So we know that for non-underweight people in particular, and that is about 80 or 85% of people with eating disorders, though they don't show up on the radar as much as the underweight cases. But for that 80%, CBT really has got a good chance of being effective. A critical thing though, and I don't mean to sound like I'm going off protocols here. Most protocols are written with the words in them, you need to, well, effectively, you need to flex this therapy to the patient in front of you. And that's something we teach all the time when it comes to delivering CBT. You've got to make the therapy fit the patient, not try to make the patient fit the therapist, fit the therapy. So I think it's fairly obvious. Nobody has yet come up with a stereotypical person with an eating disorder or a family with somebody with an eating disorder. People are, as I'm fond of saying, stubbornly individual, stubbornly different. And that means we as therapists, we as clinicians, have to move the therapy to fit those people. It can't be expected the other way around. However, when you do that, the really nice bit is it seems to work almost regardless of the problem the person presents with. So, for example, it's commonly said, oh, that person's complex, or that person's had that problem for a long time. I'll come back to that. But that person's had that problem for a long time. That person's complex, therefore this can't work. Actually, there is almost no evidence at all about that. What we do have evidence about is that if you do CBT for eating disorders and the person has comorbid anxiety or depression or personality issues or low quality of life or alcohol use, those comorbid problems tend to go down alongside the eating disorder. It's a general rule in CBT. Treat one thing well, watch the other things, if not deteriorate, at least lessen. We in our 10-session therapy for bulimia and binge eating disorder, we see people with anxiety and depression, their levels go from the clinical to non-clinical range, and we never talk about anxiety and depression. So you get this nice rolling effect. Once you start helping people get better in one area, other areas improve. So we know that we can do this relatively quickly. We know we can do it online. We know we can do this in groups. So we've been expanding out this therapy for the last 10 years or so to make sure it fits the world. There's been this thing called COVID. You might have heard of it. Almost every clinic in the UK just shut overnight. So we learned real quick that if you're going to do anything, you've got to be able to make it work online. And we've been amazed at the fact that with the therapies that we test out online, the outcomes have been just as good as in person. Not by telephone, but definitely online. So that's something well worth remembering for the future, because there are so many people who are a long way away from the therapy center. Let's help them get better by actually making the therapy fit to what they need. So that's the broad background. That's the stuff I'd like you to take away that says, oh, maybe CBT for an eating disorder can be useful. But now we hit the what's it involve? And this is a bit where when you start looking at the kind of opinion. For some reason I went mute. I have no idea why. Let me restart from this point. What I'd like you to remember is we've got evidence that CBT for an eating disorder can work. However, when you start getting into the opinion-based literature, CBT is often presented as this uncaring, unfeeling kind of approach. I'd argue that's completely off the beam because I've worked with a lot of people with eating disorders, a lot of trainees, a lot of colleagues. They're the nicest bunch you could ever hope to meet, but they care about keeping people well and they care about getting well. And so we have to be honest with our patients. Getting well is tough work, but it's well worth it. So that's a kind of broad thing to bear in mind here. So let me tell you about CBT in general, and then I'll come back to what we'd be doing in CBT for an eating disorder. Okay, now, first thing to say is CBT was set up to be a very transparent model of treatment, very focused on the here and now, unless you need the longer term perspective. So we don't look at unconscious worlds, we don't look at unachievable knowledge, etc. We're very clear about we want to see what's going on for that individual. And we share this with the patient at every step. So we have our hot cross bun, that diagram you can see there, where we stress to people that all within that big green environmental context, you've got cognitions, you've got emotions, you've got thoughts, you've got physiology, and they all tie together. And if you change one, the others will change. So, for example, if you stop eating, there'll be physiological consequences. You will start starving. You won't be able to think straight. Your emotions will start becoming more unstable, etc. And because your emotions are more unstable, you try to get your emotions more stable by trying to restrict, and that leads to more of the problem. The cognitions get even less and less flexible across time. In short, we use this kind of model to say, let's try to understand what's going on and why some of your behaviors, some of your emotions, your physiology can all have effects. It is absolutely critical in pretty much every disorder that we talk about the biological side. Sometimes you'll see people represent CBT as being about the cognitions, the emotions, the behaviors. That is pretty much a travesty of the real position. So remember the biology. And if there's one disorder where you need to remember the biology, it's going to be eating disorders. I was counting the other day. I managed to find 8 different books and a couple of podcasts and a couple of other media, all of which had roughly the title of It's Not About the Food. And my take on that is, generally speaking, probably at the time the eating disorder developed, it wasn't about food. It was about control. It was about perfections. It was about regaining some sense of self-esteem in a world that appears quite toxic sometimes. However, by the time the person gets to me as a clinician, you better believe it's about food. It's about food every inch of the way to get the person out again. And then it's about rebuilding the rest of life. So we have to always remember, do the basics first. I often see clinicians who think, well, if I talk to the patient or if I work on their body image to start with, they'll be happier. And the problem for many of our patients is that's a bit like saying to them, we want you to fight a battle, but you're going to do it with one arm tied behind your back. It's not fair, and our patients deserve better. So we always start with the basics before going on to the more complex stuff. It doesn't mean the complex stuff doesn't matter. It doesn't mean we're going to ignore it. But we want to make sure that we can do this right. The analogy I use quite commonly for this work is it's a bit like building a house. The thing I really want to see on my house is the roof goes up, because then that tells me the house is there. But if I try putting the roof up without the foundations, without the walls, that roof isn't going to stay up very long. So we start with the foundations, we work our way up, and then we do the roofing. A key thing with CBT, the behavioral elements are critical. It's the B in the middle of the CBT, cognitive behavioral therapy. And to be effective, cognitive behavioral therapy has to be doing rather than talking. In short, the stuff that is most effective in getting change is behavioral change. Because if I get the person to change, whether it's, say it's in depression, it might be behavioral activation. If it's in anxiety-based disorders, it might be exposure therapy. Either way round, I know full well that if I can get the behaviors to start changing, all the rest starts following. And I'll see changes in beliefs, in biology, in emotions, social function, quality of life, motivation, therapeutic alliance, they all follow from getting that behavioral change. And I'd love to say I'm making this up, but seriously, there is a huge amount of evidence about this out there. And it's real clear about this. We start with behavioral change. Sometimes people say, but surely you've got to have a good alliance to make the behavioral change happen in the first place, or you've got to work on motivation first. All the evidence says, no, it doesn't. It doesn't work that way around. The way I'm fond of putting it to my trainees is sometimes, people like you, people value you more if you help them start get better. So we start on helping people to make changes so they begin to trust us much earlier. But the change is more effective if it's early. Again, critical point across CBT in general, early change is what makes a difference. The best predictor of whether someone is going to recover is not how depressed were they at the beginning. It's not what trauma have they experienced. It's not have they got a personality disorder diagnosis as well. It's how much change they make in the first 4 to 6 sessions in terms of changing their eating behavior, starting to put weight on, etc. And this is something which is there throughout the anxiety and depression literature. Early behavioral change is what we're looking for. So if you or your family member are thinking, okay, well, we'll go in and we'll spend a few weeks just kind of getting to know each other, etc. Any good CBT therapist worth their salt is going to be saying, you'll get to know me absolutely fine. But we're not going to do that and nothing but, because that would be doing you a disservice. Other things that we do in CBT, we measure progress, we measure outcomes. Every session, I'm going to be sitting down with a questionnaire that I've given the patient, and I'm going to be saying, okay, let's look what happened this week compared to last week. Let's look at your questionnaire from last week and this week. Look, that thought has changed. Why do you think that might be? Is that something to do with the homework that I've got you to do? Another critical bit about CBT is it's not isolationist, where it's important to get other people involved, where it's appropriate to get other people involved, we do. Now, obviously, when it comes to getting family involved, once the person gets to an age where they can say no, then we'll work more on, can we get the family to come in the last 5 minutes? Would that be useful? Or we say, well, take the message home to your family. As long as you get other people involved, because that's such a great way of helping people to benefit, knowing that they're not on their own, knowing that they can turn to other people for support, and knowing that they can actually explain what happened in the therapy session to family, friends, loved ones, etc. We develop up an effective working relationship. Now, this is not along the lines of just empathy, it's firm empathy. Not my term, Terry Wilson's term, but it's a lovely idea. It's this notion of, yes, I understand this stuff. Yes, I understand life is pretty terrible. I understand it's really scary to think about changing your eating, for example. But I also start to understand that if we don't help you start changing, you're not going to change in the long term either. So my job is to be a complete pain in the neck. And I'll come back to that as I go along, because I've got a fairly useful way of doing that. But our way of looking at this is, my job is to be your coach. Your job is to learn to be a therapist. Why? Because CBT operates on the principle of therapy should be 168 hours a week, not 1 hour a week, 168. That means I've got an hour to tell you how to do this over the coming week, to listen to your fears, to help you deal with the fears, and then get you to go out and do it anyway. If I can treat you for only 1 hour a week, my chance of helping you go down like a stone. And like I say, unlike my patients getting better. So I don't have any problem with saying, okay, I'm going to push because I care about this person doing well. We in CBT work to an effective agenda. One of the things I've learned over the years is you write the agenda at the end of the previous session so that you're ready to get going from the minute the patient walks in. It's on the screen. Let's talk about it. What bits do you want to add to it? We're there. We also use boundaries on time. We don't have open-ended therapy. In the bulk of CBT, it's going to be, okay, we're going to meet for 15 sessions, 20 sessions, 30 sessions, whatever is likely to be effective. And we start the prep for the end from the very beginning. Now that really matters because it means I'm starting to get the patient thinking, oh, I better get my skates on here, better get rolling quickly. A critical thing here is, of course, clinicians' own anxiety. Many clinicians have a need to be liked. Well, we're only human after all. But that means for some people, if they're relatively anxious as therapists, they don't push for change from the patient. Critical way of dealing with, be honest from the beginning. Be honest with your supervisee, be honest with your patient, be honest with yourself. This is going to be tough work, but it could mean the person gets their life back. So those are some broad general principles about working with CBT. What's that got to do with eating disorders? And very commonly you'll hear people say, well, yeah, but eating disorders are different. They're a whole different ballgame. And while I'd love to say I think that's true, actually, I think there's a huge amount in common when it comes to the effective therapies. One thing that we work on the basis of is eating disorders are like a very focused form of anxiety disorder. And there's a huge amount of anxiety we have to overcome. Fear about food, fear about what my body looks like, not being able to tolerate my own emotions, etc. We spend time working on those. So what do we do in CBT for eating disorders? Now, this is where we start thinking, okay, what do we need to do in order to help the person get well? And we start out with a broad structure. So we have the same principles as CBT for other disorders, many of those same skills. So if you learn CBT properly, it's actually relatively easy to transfer across to CBT for eating disorders because it's no huge surprise. There's a couple of things you're not used to, like working with food, etc. But it shouldn't be a huge surprise. But we also, again, this is the nerd factor, tend to go for structures that make sense. So the diagram on the right is just that 10-session therapy I was talking to you about. That's what we're aiming to do, different phases that overlap, which get at all of the core problems. Now, I have to stress, this doesn't always tie up to what the person who's come for the treatment wants. So what we have to think about is, what are we trying to do? Now, here's where, again, nerdishness, evidence, etc. We define what we want to do for the patient by what they need to do, never to come back again. I like my patients, but I don't want to see them again. I want them to get well and not need me again. I want them in 5 years' time to go, who is that weird person I used to see? Or better still, eating disorder. Oh, yes, I did have an eating disorder. How do we make sure people stay well? Well, we do have, fortunately, some very neat guidance about this. So therapy, when it comes to CBT for eating disorders, these are the 4 big things that we aim for. We want to normalize eating attitudes. Do you remember that graph I showed you a little while ago when graphs came neatly under the red line? That's normalizing eating attitudes. We want the person not to be underweight. So not kind of, oh, they've put on some weight, I'm sure it will just carry on going up. We want the person not to be using binging or purging anymore. And we want a normalized body image. Obviously, what we're talking about here is not body satisfaction, because that sure as heck ain't normal, however desirable it might be. So we go for body acceptance. If we can achieve those 4 things, we've got a really good chance that we'll never need to see that patient again. We know from Fairbairn's 1995 paper that if you do well with the therapy for sort of CBT for an eating disorder, 6 or 7 years later, you're still doing well. That's a good target, but we need to get more people into that category of doing well, which fortunately since 95 we have done. Of course, it's absolutely critical we have to maintain safety. We have to make sure our patient is okay, is safe, is not self-harming, not suicidal. It's back to Marshall and Hearn here, I'm afraid. If somebody is unwell, you don't pretend you're doing therapy, you make sure you're doing life-saving. So that's a critical underpinning theme with CBT freedom disorders. We make sure the patient is safe, and then we start applying the targets. What are our core cognitive issues? Again, this is something in CBT we always start out with. We're doing it right. We say, not just come on in, we'll do therapy, but what are the problems? How are we going to make the therapy attack those problems? So one of the issues that we address, and this is usually the first one, is what we call the broken cognition. Now, for most of us, Christmas has come and gone not that long ago, or Thanksgiving, whichever it may be. We know that over a festive season, we might eat a bit more, we might drink a bit more, and probably as we eat a bit more, our weight will go up a bit as well. However, when we get past the festive season and we buy a gym membership and we stop drinking quite so much, we eat a bit less, our weight will probably trickle down. In other words, the weight and the eating are fairly harmonious. They're linked to each other. We understand that. For so many people with eating disorders, that link has gone. For so many people with eating disorders, whatever I eat, my weight will shoot up out of control. And what I need to do is to stop eating so much, or preferably starve myself completely, in the hope my weight won't shoot up or might even drop a bit. So a huge part, the early part of CBT freedom disorders is learn that link again. So we play with food, we get the person to change their food patterns, and I'll talk about that a bit more in a couple of slides, in order to start learning, oh, do you know what? I can eat and my weight doesn't go out of control. Of course, that means getting people to face their fears. You know, what's the last time you saw anybody learn to swim? We never would go in the water. So our job is to help people learn that they can get in the water and it's relatively shallow and they don't drown, metaphorically speaking, of course. The second element we want to do is look at emotional instability. This is huge for a lot of our patients. Now, sometimes it's partly explained by the atrocious intake of particular foods, particularly carbohydrate, that a lot of them have. So when you come to me for therapy, you better believe we're going to be starting off by talking about breakfast and granola and toast, etc., to start helping people build up their tryptophan and serotonin levels so that their emotions get more stable. But that will not deal with the problem for everybody. So we have a range of emotional stability measures that we use. And then the other core cognitive target is body image. I'm hoping that's not contentious to anyone. Poor body image at the end of therapy is a great predictor of relapse. As I say, I don't want my patients relapsing. However, if you ask families, if you ask patients, if you ask therapists, what do you want? They will normally say, I want to start with the emotional and the body image problems. There's a couple of bits of research, Northern Boston and Emanuele have both done this work, found the same kind of thing. So lots of clinicians tend to say, okay, let's work on your emotions, let's work on your body image, because that's what you want to do right now. But as I said earlier, that's a great way of not doing very well. So it would be good if we could make sure that we actually got clinicians used to the idea of start with the stuff that is vital. And that's normalizing eating, normalizing fears about food. Many people have tried working at this the other way around. It hasn't worked. So we want to start with the normalizing eating and fears around food because, I, like every patient I've ever worked with, I want to get that body image stuff. I want to get the emotional stuff because that's really vital to help the person get well. So the quicker I can get it done, the better, because the quicker I can get through the food stuff, the more time I've got for working with emotions, body image, and making sure that patient walks out the door and doesn't come back for good reasons. Notice what I'm talking about here. That's very much doing therapy. We're not talking about eating food differently. We are getting the patient to eat food differently. Unfortunately, when you look at our rates of patients dropping out, attrition rates, etc., they're quite low compared to other therapies, even though we're pushing, because surprisingly or not, our patients get it. They do understand why we are pushing them the way that we are. So a little bit of a kind of, what are you going to see if you do CBT-free eating disorders? And I'm going to go through it in roughly those phases I talked about before. And hopefully this will make sense. So number one, behavioral and dietary change. We will be doing exposure therapy around food because we want the person to eat differently, we want them to face their fears and take risks, and particularly around carbohydrates, because those carbohydrates do have positive effects. Apologies, my picture of a sandwich appears to have slipped somewhat. What that says there is that we also want the patient to learn that foods don't have the feared effects, that you don't get the uncontrollable weight gain. Even where weight gain is needed, we need the patient to learn it's quite hard work, it takes time, but it's controllable. So what I'll be doing is I'll be weighing the patient. The patient will know their weight because they need to in order to make that link between what I eat, what happens to my weight. If a clinician, by the way, says, I'm doing CBT, but I'm not going to tell you your weight, they're not doing CBT. What they're doing may be ingenious, but it ain't CBT. So I want that patient learning that I have to eat loads of extra food for my weight to actually go up, even though I was terribly afraid of that. We also want the patient to learn something else, and this has come out in multiple studies. And it goes all the way back to the Minnesota study, if you like. Eating from the beginning has all those additional early benefits. We did a study a while ago where we looked at what did our patients fear most about what would happen if they ate differently. Anxiety and weight gain were the two big things at session number one. Were there any benefits? None. Okay, ask the question again at session 5. What are the benefits? Loads of benefits came out. Social, cognitive, emotional, I can think straight again. My emotions aren't all over the place. What about the anxiety? Not one person mentioned the anxiety. That's after about 5 sessions. The anxiety is short-lived. That's the point we're making. The fear that we're going to make people gain weight, they start realizing just how hard it is to gain substantial amounts of weight, even if we're trying to get them to do so to get them to a healthy place. The other thing about behavioral dietary changes, if you're working with ARFID, this is central. Almost all of the effective treatment for ARFID is about getting people to use exposure therapy around food. And if you've got any doubts about that, the book by Jenny Thomas and Cameron Eddy is great if you're a clinician, but they are bringing out a version which may now be out, I'm not sure, which is aimed at families, aimed at sufferers. Get yourself a copy if you've got any doubts about whether ARFID is something to pay attention to in your family's case. We then move on to experimenting with feared foods. I'm hoping it's no great surprise that many of our patients have particular fears of foods they're afraid of. They're usually foods that were craved or binged on because they're the ones that you ended up actually basically craving and needing. You cut out some foods, your body will fight back. This is a line I commonly use with my patients. I am not going to fight with you. You're in a fight, yes, but it's not with me. The fight is between your body and your head. Your head is saying, I don't need the food. Your body is saying, I really, really need the food. And the fact that I really need to make the food means either that my body is deteriorating if I'm very underweight, or that I'm likely to end up binging if I'm normal weight or above, or indeed sometimes when you're underweight. So what we do with behavioral experiments here is we teach people to learn that these foods don't lead to uncontrollable weight gain and they don't make you overeat or binge. And I've picked a particularly nasty example here, a chocolate cookie, where there's 2 things to fear and we will go for that maximum fear so the patient learns more quickly. You know what, I can eat cookies and my weight doesn't do what I thought. I still remember going back years, a patient of mine called Steph. And the way she looked at me, it was about 5 sessions in therapy. She'd had multiple therapies before, and nobody ever suggested she might try eating food. But yeah, that's not that uncommon, unfortunately. But when I said, okay, let's try changing your diet, let's get some carbohydrate in there. After about session 4, she never binged again. Her borderline features disappeared over the horizon because her emotions were more stable. And I remember her looking at me saying, I have spent years and years of my life trying to diet and ending up binging and putting weight on. And you're telling me that if I normally, using the word in inverted commas, my weight and my eating become much more stable. To which my answer was, I'm not telling you that. Your whole body's telling you that. Which was a rather nice day. She was a lovely woman, Steph. We also don't worry about feasible dietary preferences. If somebody says, I'm on a vegan diet, that's okay. Yeah, you'll probably need to eat quite a bulk more food in order to get the carbohydrate and the protein that you need, but it's perfectly possible. It's only when the dietary preference becomes something that is pretty much impossible to achieve, like I can only eat food that's blown off a tree, on a Tuesday on the left-hand side of the tree, that we start calling that as part of the pathology. I remember when veganism started to become really popular about 8 or 9 years ago over here in the UK. So many clinicians went, oh no, calling yourself vegan is just another way of pretending that you can't eat food. And I never got that one, never understood it. I wouldn't say that if somebody were Hindu, for example. I'm not going to say it about somebody who's vegan. Most of our patients who start vegan stay that way. Kind of says they probably were. Once we've got the eating straight, once those serotonin levels are okay, we can start working on the emotional factors. Now, sometimes they say these aren't big. They're not even, particularly there by the time we get to the end of the feeding element. But where they are, then we want to deal with those, because when you're feeling very distressed, you'll use safety behaviors. You'll try to block out the emotion. You'll binge eat. You'll make yourself sick. Ways of controlling the emotion you've got. So obviously we want to deal with those because we don't want those behaviors around anymore. And there are different forms of addressing this in different therapies. So for example, emotion management skills, taken from Marshall Lenehan's DBT model, dialectical behavior therapy, based around emotional invalidation, emotional inhibition. It's not safe to experience or express an emotion. Therefore, what I'm going to do is I'm going to kind of just shut down that emotional part of myself to the point where you can even read it biologically in brain function. That's a pretty nasty state to be in. However, we also, in some versions of CBT, work on modifying the emotions themselves. So instead of teaching people to sit with the emotion, we want the person to actually learn how to change the emotional state or how to change their response to the emotional state. And that's more important. One of the things that's critical about emotions is they're not bad things. Despite what people sometimes say, an emotion is a motivator. It's there to communicate to you. When I'm anxious, I want to resolve the situation. If I'm lonely, I want to pick up the phone and talk to someone. If I'm happy, I want to do it all again. Those are motivators. And if we ignore them by being sick or going for a run instead of eating, etc., we use those to avoid emotion. We don't resolve the emotion. Big problem. So we use techniques like habit reversal, exposure with response prevention, attributional shifts, imagery scripting, and counter-schematic behaviors, all of which sound horribly jargonistic, but they work. And again, if you're seeing somebody with a CBT for eating disorders qualification, or who's offering you that treatment, they should be able to fill you in on that based on your experiences. You don't need me trying to do that at this stage. The final stage, though, is working with body image. Now, it's actually quite hard to find a specific trigger to negative body image. The way we describe it to our patients is you've probably lived most of your own life through this toxic swamp of experiences, particularly if you're female. The messages you've received, the thin ideals, etc., the teasing, the bullying, the traumatic relationships, sometimes for men, but more commonly for women. And that means it's really hard to pick one thing that really ended up saying that is why I've got a negative body image. So we work with maintaining factors, work with body checking, body avoidance, mind reading, comparison. There's a whole set of methods for working with these, but we don't apply them all to everyone. You know, if I'm meeting a patient from the very first session, I might be thinking, how are they dressed? Are they checking what their body looks like? Can I pick up cues about what that person's maintaining behaviors might be, so that I know what I'm going to be doing in 5 or 6 sessions or 10, 20 sessions, depending on the nature of the problem. We always want to match the intervention to the problem when it comes to body image, because there's lots of things that can maintain the problem, and we want to make sure that we address the right things. So we have a little list here of things like, you know, if someone's got hurtful body memories, you might work with imagery rescripting. If they've got mind reading, you know, I know they think I'm fat, then we'll use surveys. If they avoid looking in mirrors or hide their body, we'll use exposure therapy. All of these are tough because they're helping the person, but they're helping them by breaking long-standing patterns of safety behavior. And obviously, anytime you change away from a safety behavior, you will feel anxious in the first instance, but long-term, much, much easier. So that's a kind of broad picture. If you go into CBT for an eating disorder, or if you're inquiring about it, I would hope you would hear about a lot of things I've been talking about here. I'm hoping you'd hear about the use of one of those manuals I talked about earlier on, put up earlier on. So finally, one thing to bear in mind. When we develop any therapy, we should always be looking for people who don't get well. So I would say, while CBT for eating disorders is an option that should be high up on your list, and we should be avoiding the kind of stripped down versions and the anxious clinicians who don't really deliver it, no one can pretend that CBT or CBT for eating disorders are perfect. There's always going to be more avenues to explore. You know, at the moment, if somebody with bulimia nervosa walks into my clinic, I can honestly say to them, you stick with this therapy, you've got about 60 or 70% chance of recovery and staying recovered. Same for binge eating disorder, lower for anorexia nervosa. But those numbers are not good. Until we can say it's 95 to 100, we should always be open to the possibility that better things will come along. So recently we've been doing some involvement of compassion-focused work into the CBT in the hope that that will help with trauma treatment. I can't talk about the data from that yet because they haven't been released, but we're getting some interesting results. The critical thing is, don't let new exciting add-ons become a substitute for what we already do. These should be things that we use as a way of enhancing what we're already doing. I suppose the message I want to leave you with is, we have some really good ways of helping people get better. It would be so nice if we got better at them. And if you guys felt confident enough to think, maybe that's something I should be doing. Maybe I should be getting myself, my child, my loved one into a therapy that's got a pretty good chance, you know, from adolescence upwards. Okay, I'm going to stop at that point and I'm going to ask Judy, are there any kind of key questions that people post that they'd like me to address?
Yeah, so first of all, thank you. That was incredibly informative and comprehensive, and you packed a tremendous amount of very relatable and understandable information into a short period of time. So first of all, thank you. I'm just going to go down the list of questions and get to as many as we can. So the first question is, as a parent, how do you assess whether the treatment is working when you are not included in the sessions? How do you gauge whether the therapist is truly administering CBT-ED appropriately?
Oh, I mean, that's a really good question. And my first reaction is always, why is the parent not involved? If the child has said, I don't want my parents involved, okay, I get it. But if it's the therapist saying, no, this is not something for you to know about, then I'd be very wary about whether what they're getting is going to be an appropriate therapy. Because when you're a CBT therapist, you use any resource you can, and that definitely includes the parents. So that would be my first question. If it's the case that it's the offspring who doesn't want to talk about it, then I tend to say, well, let's look at how their eating disorder is going. If it's not doing well within, maybe 10, 20 sessions, I'd be saying, this doesn't sound like it's working. But I would want to talk with my child about what are you having in that therapy, not to reach a judgment about it, but just say, does that sound like anything I've heard here today? My fear is that you might sometimes hear that it won't be, in which case, consider yourself armed to ask the right questions before your child starts the therapy, because that's what today has been about from my point of view.
Okay, thank you. Next question. How effective is CBTED for someone who's severely cognitively affected? Does there need to be a certain amount of weight restoration first?
Yeah, we always would say you don't need to necessarily do weight restoration, but nutritional restoration. So as long as the person's getting enough carbohydrate into their diet, then they've got a good chance of being able to understand this stuff and being able to respond to it. But if they're severely underweight and their carbohydrate intake is low, or if they're regular weight and their carbohydrate intake is low, it's real hard to think that way.
Okay, thank you. Okay, next question. Is there any evidence for the efficacy of CBTED and autism?
We've got some evidence that we're building at the moment. We like the area because it's such an important one, really, really huge. However, what we find with autistic spectrum problems is we have to refine the therapy. So there are some things we don't try to do and some things that we do in a more rigid way. Always, again, remembering autistic spectrum is such a wide spectrum. So, for example, a recent patient, we wouldn't do surveys because it's about understanding what other people think. It's not a great one. But most of the people like that I've worked with, as long as you've got clear sets of behavioral rules, they tend to do really well with them. So, when we looked at very preliminary data about our subset of people with autistic spectrum disorder, they tend to do really well. We just don't try to make it as cognitively challenging, go much more down the behavioral route. And the same applies, for example, with intellectual disabilities. Again, we go much more behavioral.
Okay, you covered another question without intending to, so thank you.
Oh, okay.
Okay, next question. Is there any difference in efficacy for CBTED in anorexia versus binge eating disorder?
Yes. You remember I said earlier, the rates we'd expect maybe around 60% for binge eating disorder. It's about 30% for anorexia nervosa. Do you remember I said there was a need for better therapies? That's why. Until we get really good at working with anorexia nervosa, we should not be confident. Problem is, of course, we don't have any therapies that are better than 30%. Pretty much everything evidence-based is stuck around that kind of level at the moment. We have plans, but not for talking about today.
Okay. How long should CBTED continue for? I mean, what's the normal course of the treatment?
It varies. If it's somebody who starts off at a normal kind of weight or overweight, then anything between 10 and 20 sessions, depending on the protocol that you're working with. If it's anorexia nervosa, we usually find about 30 is sufficient, but I know F.E.A.S.T goes up to 40. But the key thing here is always, you will know within half a dozen sessions whether that person's got a good chance of doing it. You should hear me in session. It's kind of, okay, this is session number 2 out of 6. Let's have a look at how you're doing compared to last week, because that's really important. Because by the time we get to session 6, I want to see real big change so that we know that it's a good idea to carry on from that point. So yes, there's a very distinct difference. And the length of time that we use depends on how much weight gain you've got to do. I still think we could do it quicker, but I'm like that.
Okay. If someone is saying that they're motivated and on board, but they're repeatedly not making the behavioral changes, how do you proceed? Such as they continue to say that they're motivated. Well, that's the same thing. Never mind. That was the question. If someone says they're motivated, but they're not making the behavioral changes, what do you do?
Okay. Well, first of all, never assume that somebody with an eating disorder is unmotivated. In my experience, they're always motivated. They're just not motivated for the same thing that we want all the time. So, many of my patients are really strongly motivated to stay exactly where they are, thank you, or to lose some more weight. The fact they're not motivated to make the things that I think are important for them in treatment is something that I'll address from the very beginning. And if the patient continually doesn't make those changes, there are kind of three broad approaches to that. Walter van der Eycken used to talk about having a blacklist of patients, which I wouldn't approve. Josie Geller talks about, if you like, strategic disinvestment, where you say, okay, step back, come back when you're ready to do therapy, and learn that all the things that you were trying to get out of therapy aren't working for you. We use a thing that we call disability training, where we help people to realize that actually they really are going to see a deterioration in their life if they don't start making changes. They all have their benefits, but they also all take a huge amount of, let's say, nerve on the part of the therapist. You know, every time I start working with a patient using disability training, I always say, what if this doesn't work? But I know that if I don't try it, I'll still be seeing that patient in 2 years and they'll still not have pushed forward. So we are prepared to say, we can't work on this at the moment, or we can do what Palmer used to do, which is see you every 3 months to see that you're okay. But, you know, we're not going to pretend we're doing therapy. So those are the broad approaches to it. But we do our level-headed best to make sure that we make behavioral change so quickly that we rely on true motivation. You know, motivational interviewing doesn't really work with these patients terribly well. All the evidence says so, but positive reinforcement does. So I want my patients starting at the very beginning thinking, oh, I did something well in that first session and I'm getting patted on the back for it. Maybe I could do some more of that. It sounds very simplistic, but it's well worth giving a try.
Okay, one final question. How do you manage resistance to focusing on food or taking weight? Do you have any recommendations for preventing disengagement at this stage, if that feels particularly threatening for a patient?
It depends whether you want to do CBT or not. I know that sounds very harsh and, you know, black and white, but it is very harsh and black and white. If the person's not prepared to learn that my eating, i.e. keeping records, and my weight, i.e. getting on the scales and knowing what weight is, if they're not prepared to learn either of those, you can't help them to recover. So I'll tell you what I do in session number 1. And you can think, Glenn is probably the nastiest person in the world. And there are people in this room I know who'd be prepared to back me up on that. Hi, Jamie. But I would say to the patient in the first session, we're going to weigh you. I remember having a conversation with Jim Locke about exactly this topic once in FBT, and coming up realizing we were very much the same person. Patient says, I don't want to be weighed. My response to that is, well, that is absolutely your right not to be weighed. I'm not going to insist that you should be weighed at all. But it's also my right to say to you, then we can't do this therapy because, you know, the therapy depends on that. So if you decide that you don't want to be weighed, that's absolutely your right. I will say goodbye. I'll see you next time that you seek a referral, and knowing what the rules are. Every time I've done that, I always think, what if they walk out? What if they do what if I've driven them away? I've never yet had a patient walk out during doing that. The reason being that I think it sounds very blunt to say called the bluff, but I've gone for the safety behavior of they'll back off. Then I'll back off if I say I'm not doing it. And I've taken that away. And every time I've managed to get the patient weighed in that session, I have been called some very nasty things. And again, they're probably very deserved. But as I say to my patients in session number 1, I don't care whether you like me or not. It's not important. I don't need you to like me. I need you to get better. So sometimes I'm going to be a complete pain in the ass. I'm going to push you to do things that you don't want to do. You're going to hate me. That's okay. Just keep working on the therapy. And when we do our reviews at the end, that's a comment that comes up so strongly so many times. It was a real revelation to hear that it was not something where we were going to play a game of liking each other. We were actually doing a job of work. And now our therapeutic alliance scores come up really scarily high, given that we are kind of very boundaried around this sort of stuff. So I would strongly advocate, if you want to do CBT, you want to weigh the patient, you want to have the records. And if the patient's saying, I'm not going to do it, work with that straight away. Don't give it a few sessions, say, I'll weigh you next week or the week after Labor Day or whatever it might be.
Thank you. Unfortunately, we've run out of time, so we can't answer more questions. Thank you everyone so much for being here. If you liked this webinar and you'd like to support F.E.A.S.T so we can continue offering these type of services, please go to our website and donate what you can. Next month, we will not be having a webinar because we are having our Feast of Knowledge conference. I hope you've all heard of it. It is all over our website. If you haven't registered, please register, whether you are a parent or a caregiver or even a provider. I promise you will walk away with a lot of knowledge that you didn't have before. Thank you so much, Professor Waller, for being with us today. Thank you all for participating, and I hope to see you all at Feast of Knowledge.